Hello my dear friends, I'm Dr. Vaishali Bharambe, Professor Anatomy. This is a question very often asked. Describe bronchopulmonary segments. Okay, it's carrying a good 15 marks and you're looking so stressed. Today we're going to try and solve this question so that you can attempt this very commonly asked question on bronchopulmonary segments. Come. So this is the lung series going on. Today we are discussing bronchopulmonary segments. Links to the rest of the videos are given in the description section. Anatomy of lungs, bronchopulmonary segments. So I'm requesting you to sit with a color pencil set and maybe a drawing book because I will be asking you to draw. Let's define a bronchopulmonary segment first. It's a structural and functionally independent unit. It's pyramid shaped. It's aerated by a single tertiary bronchus and it is supplied by a corresponding pulmonary artery. Sounds like a very complicated definition, isn't it? Let's understand. I'm sure we'll be able to define it exactly in this way later, but with more confidence. Come. Oh wow, yummy. This is a wedge of watermelon. Our bronchopulmonary segment is a well-defined wedge-shaped structure. And that's why this wedge. So focus on understanding first the concept of bronchopulmonary segment. Please have some patience today. For understanding this, the journey begins with trachea. There will be a few added applied anatomies I will be adding because I really want you to understand the subject as a whole. Okay? You can delete it from your brain if you're not interested in knowing it. So let's begin. Here you're seeing the trachea dividing at the level of the sternal angle into right and left principal bronchi. The point at which it divides is called as the carina, which is an angle of about 70 degrees. Inside the carina, there is a little ridge, okay? So if you're doing bronchoscopy, that ridge gives you an idea that you've reached the point where there's going to be a bifurcation now into right and left principal bronchi. It's a very sensitive point which sets off severe cough reflex. If a foreign body is able to cross this, then it enters inside the lung. It's the last line of defense. This carinal angle can be blunted in case of tumors occupying this region from 70 to much more. So build a little carinal angle in your brain. I'm going to now tell you the story of the principal bronchus. Believe me, it's needed for bronchopulmonary segment. Come, let's begin the journey. There was a trachea. It got divided into two principal bronchi, right and the left. That's how the story goes. Then it got divided into secondary bronchi. See here. Which then got divided into tertiary bronchi. See here. And the area of lung aerated by one tertiary bronchus is called as a bronchopulmonary segment. Easy? The area of lung aerated by one tertiary bronchus is called as a bronchopulmonary segment. See there. Nice and wedge-shaped? Yeah. So, once the air has entered into a bronchopulmonary segment, the bronchi will undergo 16 to 18 further divisions before they form respiratory bronchioles and finally release air into the alveolar sacs. That's how much division is expected. If you're enjoying this, do please like, share and subscribe to my channel. Now let's explore the journey of right principal bronchus and left principal bronchus from the hilum onwards. Okay, right principal bronchus first. It's wider, shorter and more vertical. It forms barely an angle of about 25 degrees with the midline. You just imagine that it's a more vertically placed bronchus. What will happen if were you to inhale a foreign object? Would it go on the right more or the left more? Of course, it will go on the right because that's a more vertical path the foreign object finds. As the principal bronchus passes, it's covered on the top by the azygous vein. Like I told you, aspirated foreign objects are more likely to enter into right lung because of a more vertical course of the right principal bronchus. After that, it divides into an eparterial and a hyparterial bronchus. The one that supplies the upper lobe is called as the eparterial bronchus. It's given off just before the bronchus enters into the hilum. Here, this one. The one that goes further down to the lower lobe is the hyparterial bronchus. The eparterial now divides into three: tertiary bronchi, apical, anterior, posterior. Simple. Principal bronchus, secondary is the eparterial bronchus, tertiary are apical, posterior and anterior. The anterior segment of the upper lobe is most commonly involved in carcinoma lung. The posterior segment of the right upper lobe is frequently affected by tuberculosis. This is information you have to remember. Apical, anterior segment, CA, posterior segment, tuberculosis. Moving on, hyparterial bronchus, the one that went down. The hyparterial bronchus continues downwards. Anteriorly, it gives rise to a branch to the middle lobe of right lung. This then divides into lateral and medial tertiary bronchi. Okay. The point where the middle lobe bronchus takes origin is surrounded by a number of lymph nodes which can, if thickened, block off the entry into the middle lobe of right lung, resulting in what is called as the middle lobe syndrome, where the middle lobe just collapses. Continuing, the hyparterial bronchus goes further down. It divides into several tertiary bronchi which are apical, anterior basal, lateral basal, posterior basal and the medial basal. How many in all? 5. Okay. The apical bronchus lies almost exactly behind the opening for the middle lobe bronchus. How does this matter? Any pus in the middle lobe, when the patient lies down, drains directly into the apical lobe. Okay. So, it directly drains back into this portion of the bronchopulmonary segment. So, posterior segment of the upper lobe and apical segment of the lower lobe are common sites for aspiration-related lung abscesses. Why? Because when a patient is lying down, these are the two lobes which are most dependent. Such patients can be made to lie in prone position to drain out the pus from these two lobes. Problem in case of apical, it might drain into the middle lobe directly, where because the opening of the bronchus lies exactly opposite. This is called as a natural drainage method. I just told you it has a drawback. Let's talk about Mendelson syndrome for a bit. It's also called as aspiration pneumonitis. So what is this? It's an acute chemical pneumonitis. What causes it? It's aspiration of acidic gastric contents into the lung. Why would they do that? Why do gastric contents get aspirated? Now, this is because the airway protective reflexes are depressed, as happens in case of general anesthesia, heavy sedation. So, when these gastric juices come up, the protective reflexes are not able to ward them off and they find their way into the lungs. What do they do to the lung? They cause chemical injury to the lung, resulting in inflammation, pulmonary edema, bronchospasm. So, which lung segments are commonly affected? Like I told you, the posterior segment of the upper lobe, apical segment of the lower lobe. Why so? Because they are the most dependent segments in a recumbent patient. So, let's revise. This is trachea dividing into right and left principal bronchi. Right principal bronchus dividing into secondary bronchi, secondary dividing into tertiary bronchi. Area aerated by one tertiary bronchus is called as a bronchopulmonary segment. Clear? So this is eparterial bronchus, this is hyparterial bronchus. Eparterial dividing into apical, anterior and posterior. hyparterial giving rise to the branch to the middle lobe and a branch to the lower lobe. Branch to middle lobe divides into lateral and medial tertiary bronchi. Branch to lower lobe divides into apical, anterior basal, lateral basal, medial basal and posterior basal. In all 10 tertiary bronchi and therefore 10 bronchopulmonary segments. If you're enjoying this lecture, do please like, share and subscribe to my channel and visit my website vbanatomy.com. Link is given in the description section. So I'm going to now show you what the lung looks like and where you will find these segments. Okay, till now we were tracing the bronchi. On the lung, the image looks something like this. This is the apical, the anterior and the posterior bronchopulmonary segments. In the middle lobe, this is medial, this is lateral. In the lower lobe, this is apical, anterior basal, lateral basal and posterior basal. So these are the bronchopulmonary segments you will see from the lateral side. Looking at the image, try to imagine the posterior segment of the upper lobe and apical segment of the lower lobe. Right? So these are the common sites for aspiration-related lung abscesses. Why? Because they are the most dependent part. Now can you imagine a patient lying down? This is the anterior border, this is the posterior. Obviously these two are going to be the most dependent parts and therefore most commonly affected in aspiration-related lung abscesses. Medial surface of the right lung shows apical, anterior and posterior segments. Medial, apical, posterior basal, lateral, anterior and medial basal. Now this is a lot of repetition for me. My suggestion is draw this with me. This is so simple and so beautiful. If you draw it, if I keep on reading out, it's so boring. Just remember when you draw your lung, remember to draw your horizontal and oblique fissure. Once these fissures are placed in the correct place, your lobes are clearly evident. Now to label the bronchopulmonary segments doesn't take anything. See, upper lobe apical, anterior, posterior, middle lobe medial, lateral, lower lobe apical, anterior basal, lateral basal, posterior basal. Similarly, on the medial surface of right lung, draw your oblique fissure, draw your horizontal fissure. Again, upper lobe apical, anterior, posterior. Middle lobe only medial will be seen because lateral is on the other side. Lower lobe, this time the medial basal makes an appearance. Okay, so use your intelligence, you will find this comparatively easy to draw. I'm going to draw it with you, I'm going to release the video, do please watch for it. We now move on to the left principal bronchus. You can see that left principal bronchus is longer and has a more oblique course. It's about 5 cm in length, making an angle of almost 45 degrees with the midline. It passes below the arch of aorta. There is no eparterial bronchus here, both are below the pulmonary artery. Right, as you can see, it gives rise to an upper lobe bronchus and a lower lobe bronchus. Upper lobe bronchus now divides into ascending and descending. The ascending goes on to give rise to an apico-posterior tertiary bronchus and an anterior tertiary bronchus. The descending divides into upper lingular and lower lingular. Question, why not medial lateral? Because there is no place for a medial. Right, because now in this case, this is the side where the heart is. So there is no place for a medial. So the lobes have adjusted themselves so that there is an upper lingular and a lower lingular. Now let's talk about the lower lobe bronchus. The lower lobe bronchus divides into apical, anterior basal, lateral basal, posterior basal. Again, there is no medial basal. Why no medial? Because again, the space for the medial basal is occupied by the heart itself. That is why you find no medial lobe, you find no medial tertiary bronchus here. So let's revise. This is the left principal bronchus dividing into upper lobe bronchus and lower lobe bronchus, which are the secondary bronchi. The upper lobe bronchus divides into ascending and descending. ascending dividing into apicoposterior and anterior tertiary bronchi, descending dividing into upper lingular, lower lingular tertiary bronchi. The lower lobe bronchus goes on to give rise to apical, anterior basal, lateral basal and posterior basal tertiary bronchi. Again, remembering this is easy. There is no medial basal because the space is occupied by the heart. So let's draw the lung and depict on it, project on it, the bronchopulmonary segments. Again, I'll say draw your fissure. Okay, so here's your fissure and therefore this is the upper lobe, apicoposterior anterior, upper lingular, lower lingular. Simple. This is the lower lobe, apical, posterior basal, lateral basal, anterior basal. Done. Turn it around, look at the medial surface of left lung. Again draw your fissure. Apicoposterior anterior, lower and upper lingular. Apical, anterior basal, lateral basal, posterior basal. Very simple. If you use some logic. I'm going to release this also as a drawing label. Do please watch for it. Okay, it will help you to learn. There's no need for you to draw multiple colored bronchopulmonary segments. Just make sure you get your fundamentals right in your brain. So this is the lateral and the medial surface of left lung. Draw and label the bronchopulmonary segments in the left lung. Comes as a very common question and use this image to draw. Otherwise, use my next video to draw. So this is the summary of the bronchopulmonary segments, 10 on the right, 8 on the left. Dear students, there's a lot of variation. Some books themselves give 10 on both the sides because there's a lot of variations in bronchopulmonary segments. We have studied and defined the bronchopulmonary segment of both the lungs. What is left to be done? It's important to discuss the bronchopulmonary segment as a unit. Come. So bronchopulmonary segment is a wedge-shaped unit. See here, 1, 2. Each is having an apex and a base. Okay, it's an independent respiratory unit having its own tertiary bronchus supplying it, and each unit is separated from the other by intersegmental areolar septa. So each bronchopulmonary segment is supplied by one tertiary bronchus, by one segmental branch of pulmonary artery bringing deoxygenated blood, by one bronchial artery for the conducting tissue, and oxygenated blood is drained back through the intersegmental septa by tributaries of pulmonary veins. Okay, so the veins are intersegmental, the arteries are belonging to each segment individually. So this is a nice big image. Do use it for drawing. This is one bronchopulmonary segment. This is the tertiary bronchus bringing in air. This is the segmental branch of pulmonary artery, and here is the bronchial artery. These are the tributaries of pulmonary veins which are going to carry away the oxygenated blood. Let's breathe in. As you breathe in, air enters into the bronchopulmonary segment through the tertiary bronchus. Meanwhile, the pulmonary artery is carrying deoxygenated blood into that bronchopulmonary segment. Exchange of oxygen takes place and oxygenated blood is now carried back to the heart by tributaries of pulmonary vein. This is what happens when you breathe, and this is how oxygen transfers from the air into the pulmonary veins which carry it back to the heart. So bronchopulmonary segments act as independent functional units of lung where ventilation and gas exchange occurs. So let's come to what are the functions of bronchopulmonary segments. Let's keep it very simple. They conduct air to specific parts of lung. They help in uniform distribution of air. They allow for gas exchange, common sense. They provide a functional division of the lung into smaller units. We will learn why. This structural functional arrangement helps in preserving maximum lung function during disease. That is the last thing, is the main point. Come, we'll discuss what happens in disease. So what happens is when lung is affected by disease, bronchopulmonary segments act as individual units. They try to limit the disease to one segment, to the second segment. They don't allow the spread of disease as far as possible. Disease does spread, but effort of the lung is to limit it to each segment. Okay, that's one. Second is your own knowledge of bronchopulmonary segment helps you to tell which lobe is affected on X-rays and CT scans. When you're doing bronchoscopy, again, your knowledge of bronchopulmonary segments helps you to guide the scope, helps you to locate foreign bodies. Your knowledge also helps you in postural drainage. I just told you the natural method of drainage of pus from lungs. Segmental resection of lung. See, when there is a lung pathology, okay, you want to remove a part of lung. If you have a good knowledge of bronchopulmonary segments, you would land up removing only those which are affected, leaving the rest intact. It is possible to dissect out and remove diseased segment, leaving much of the good tissue intact, and this is why you should have a good knowledge of bronchopulmonary segmentation. This kind of lung removal is called segmental resection. There is also some importance of segmental resection related to anesthesia. I'm going to leave it here for you to read because this is not at all for any average student. Do read it if you are interested. So I hope you enjoyed this lecture, and if you did, then do please like, share and subscribe to my channel and hit that bell icon. Do visit my website vbanatomy.com for more detailed lectures, downloadable notes, surgical anatomy videos, draw and label videos and much more. Link is in the description section. My dear students, I'm out here to make sure optimum anatomy education is available to every student out there. Do watch VB anatomy videos, share your doubts, I'm here to help clarify them. But let's move forward with knowledge. Your certificates don't make you doctors, your knowledge does. Thank you. I'll see you in my next video.